Well, a very good morning to all of you. My name is Ron Yeo, and my co-chair here is Professor Chi Soon Pek, and we are representing the APACRS group. And I'd like to thank the AIOS for inviting the APACRS to really co-host this session. And what we thought we would do is bring in one of the master classes that we presented in the Singapore meeting last year, in which I invited really 6 to 8 people to talk on topics that they never teach you in residency. And it was very well received then, so we're going to present most of the talks from that session. To start with, I'm just going to swap with my friend Dr. Naren Shetty from Bangalore. And Naren, as some of you will know, looks after one of the biggest and most renowned eye centers in India and internationally. And I've asked him to talk to us about, when you have ambitions, how do you develop an eye center? Naren, away you go.
Thank you so much, sir. On this onset, I would like to thank Dr. Ron, APACRS, and AIOS for giving me this opportunity. Now, the path to become a doctor is pretty straightforward. All of us know, and we can, achieve it sometime in the future. But once we become a doctor, then we just look around. There are so many questions in our head. How do we do? Where do we start? Which machine to buy? How much money I need? So many questions unanswered it goes. So at this point, we have to remember where you start is not as important as where you finish. Now, each one of us start at different starting points. Some of us start at a point where we hardly have any money in our pocket, and we have our family and friends also don't have any kind of a medical experience. Some of us start in a position where we have a lot of money with us, but we don't have any medical background among our friends and family, so we don't know much about it. And some of us start in a place where your family already has a nice big hospital chain, and you have a lot of money, obviously. So let's look at the first starting point, where what if we don't have, or we have very limited money with us, and we don't have much experience in the medical field. In this starting point, we need to be slow and steady. It is very, very important. No matter what specialty you like, be it oculoplasty, be it glaucoma, whatever it is, but make sure your cataract skills are polished, because this is going to be the bread and butter once you start your practice. Spend about, once you finish your studies, when you start practicing, work under an institute or a hospital for a couple of years, so that one, you build up your surgical skills, also your skills, how you talk to the patient, how approach a patient, and also over the years, you can, gain your funds. And it's very important to monitor the inflow, the money inflow, what comes in and what goes out. This is very, very important. You need to monitor every rupee, because at the end of 1 month, you should know how much you will have at the end of 1 year, 2 years, 3 years, 5 years, exact amount you have, so that you can do your proper planning at what point you want to start your private practice. Now, mentors play a huge role in this starting point. Mentors play a role in any starting point, but here a very significant role, because they can really guide you on where to start, how to start, which machine to buy. And because they have a good rapport with all the companies, they can get you a very good deal when you're trying to acquire a machine. And whenever you do start acquiring a machine, it's a good idea not to just buy it out. Initially, you can rent out the machine so that it's not too heavy on the pocket. And then we have a closed mindset when we look at refractive surgery. When we think of refractive practice, we think of expensive laser machines. No, let me not go into it because I don't have too much money. But actually, you can start from day one, even in this starting point, because if you can start off implanting phakic lenses. You don't need any other extra or expensive laser equipments to start your practice, so that by the time you can afford to buy a laser machines, you'll have a good amount of refractive practice also in your clinic. So it is not the salary that makes you rich, it is your spending habits. It's very, very important in this starting point. Now, coming to the next starting point, what if you have a lot of money, but not much of experience in terms of in the medical field? At this point, what you can do is you can go all out. You can, hire really good consultants in different specialties and also have the best machines. You have to make sure your center, no matter what eye problem the patient comes, try not to say that, okay, this kind of condition of the eye we cannot treat in the hospital. That scenario should never come in your clinic. Always you should be able to handle any kind of situation, at least eye-wise. And whenever you choose your location, always do a market survey and then choose a location. And when you chosen a location, look at your local competitors, see their pros, their cons, and also look at what prices are they charging the patients, so that when you open up the center, you can be a little more competitive when you open for the initial time, so that you have more footfall, and later you can always change as the time goes. Always have a good rapport with your physicians, referring physicians, because every time they refer, you need to thank them, you need to send a mail or message or speak to them that we have received it, we are going to do this kind of treatment. So this way, a long way, if you keep a good rapport, more and more patients come to you. Now, coming to the next starting point, where you already have a large hospital chain, and at this starting point, you do not be afraid to give up the good to go for the great. You need a really stepwise approach for this particular starting point. You need to get into the patient's perspective and see what they love about your institute or what they hate about your institute, and work on those feedbacks. And then you need to improve efficiency. For instance, you need to lower the lower margin. In the sense, even the smallest thing can be, those soft tissues which you use in your OPD, you can monitor on a monthly basis how much do you spend. Is it being overspent, unnecessary wasted, the viscoelastics, the gloves, all these things, step by step, you really need to monitor this, so that unnecessary wastage and loopholes for someone to cheat the system shouldn't be there. And also what we need to do is look at the performance of our surgeons in the institute, see how you can help them to push themselves further, make them more efficient, so that way, overall the hospital also grows. And also try to standardize the treatment of any kind of eye conditions, so that you improve the quality of your care from your institute. The next thing is, what is very important, we don't give too much importance, is training the paramedical staff. The counselors should know about every surgical procedure that is happening in the hospital. A lot of times they don't know what it is. They think phaco is different, femto is different. They think it's a two different procedure. And also write a script exactly what they have to speak. Because a lot of times we just give a free hand, okay, just talk nicely and then that's it. So they won't know. So you need to standardize this, so that you standardize the counseling aspect. The next thing is, you need to strategize your expansion plan. Again, whenever you choose your location, you need to do your market survey. Instead of buying out a land and then building the building, can be pretty expensive. Instead, we can always look at a plan where you're looking at a landowner who builds the building for you, and you can get into it and rent out the space. So that way, your investment for a new building is lesser, so you can expand even more faster. The next thing is, try to have an edge over over your competitors by getting into research. This way, you make sure that your whole team in the hospital is up to date with the latest and the best, and try to do some translational work so that you give back to the community, give back better care and treatment for the patients. But what is common in all these three categories is, we need to be humble. We need to connect with our patients. Even if our intention is bad, and you might be, or we might be the best actors, still the patients will get to know. So they'll be, so we can't trick them. So you really genuinely have to love your patients. Automatically, the patients come to you. Always encourage the patients to give feedback and try to upload in a social media, so that you amplify the word of mouth. And also have a healthy relationship with the competitors. Never bring someone down, because, not just your competitors, even anyone in your life. It's not a good idea. Today, you might be seeing a complication of your competitors, but tomorrow, your competitors will be seeing so many more complications of yours. So please do not get into that vicious cycle. And lastly, I would like to say, keep faith through turbulent times, because definitely there will be turbulent times through everyone's journey, because eventually, faith will always heal you. Thank you so much for your time.
Thank you very much, Naren. So while Samresh gets set up, can I just ask you one question? I know your center has both clinical services and a really highly developed research facility. So what's the philosophy of your practice, your center? Do you have a sort of motto or a mission statement? How do you balance, the need for revenue and also the expense of research?
That's absolutely a very good question, sir. So actually, one of our characters of our founding father was if you look at him, he's a simple man. He never spent money. So whatever money he earned from the institute, he always pumped it back, or pumped it back into the hospital or the research. So it was, if we think that, okay, this is money is ours and I have to spend it personally, then you hold it strong, then the institute won't grow, the research won't grow, everything. So that is because of his philosophy, his sacrifice, where he didn't buy these Ferraris or big mansions or whatever it is. He saved the money and then pumped it back, and eventually, it paid over the years. And during the growth, it's very important to do this. Yes.
It's such a great point, isn't it? I mean, giving back. Sunpek, do you have a point to make?
No, I just want to know what percentage of your revenue would go into research today.
So right now we are looking at about 4% to 5% of our revenue is going back to the research. But the thing is, it's actually, ma'am, it's more of a long-term thing, because research, I mean, we keep aside a certain budget in place so that, okay, this is what we require in 5 years for this particular research, because they're pretty expensive, and it's like we need to continuously keep pumping in. And over the years, at least the initial time, we have always self-funded our research. We didn't rely on anybody. But now, since over time we have gained popularity, the institute has grown. Now, a lot of people are interested to fund the research. And
when you need money, nobody wants to give it to you. When you're successful, everybody wants to give it to you.
Sir.
Yeah, that's a lesson to be learned. Thank you very much,
Thank you, sir. Thank you.
Naren. Our next speaker is my dear friend Samresh Srivastava, nearly, from the Raghudeep Eye Center in Jaipur. I've admired Samresh and his family's tremendous sort of award-winning movies that they've made at all the film festivals in the world, and really part of our sort of, our professional lives as cataract refractive surgeons is really making movies. And I want him to tell us how to make an award-winning movie.
Thanks a lot, sir. Actually, one of the inspirations for movies and looking at your movies and looking at the videos that you've won has inspired most of us in the room here. So I'm going to deconstruct as to what I look at when I'm making a movie with the sole intention of trying to get into the award ceremony. And that's how I'm looking at things. The first thing you need to do is have a solid idea. You need to think it through, you need to find out and have a solid idea. But once you're done with the idea, you need to do hard work, because it's not just the idea that will get you there, but it's what you do with the idea that will move you ahead. So I just want you to notice this video. This is a polar cataract that's undergone a cataract surgery. We are winding up, coffee is getting done, everything is getting ready to wind up the day. And this is just a standard routine hydration, but not always things go as you plan. And why is it that this video is interesting? I'll show you again if it plays again in slow motion. This video is interesting not only because the posterior capsule gave way with a simple stromal hydration, but for the fact that I have this video with me. And why is that? It's because I'm recording all my surgeries. So if you want to make a video that involves cataract surgery, refractive surgery, any other surgery, it's very important to make a habit of recording all your surgeries, even the uneventful ones, because you don't know where the action happens. And for this, once you've done that, and then the whole story starts. Then you want to decide whether you want to choose a theme, you want to focus on what points, don't complicate, keep it simple, keep it relevant to the audience that's listening to it. Obviously have good quality video content, and keep in mind time is always restricted. You're playing at an 8-minute schedule and not more than that for most films. So first things first, good recording setup is what you want. Once you go to the industry and you look at all these cameras, you will look at their price points and you will jump, because it's not cheap. All these medical grade cameras are really expensive. Again, you need to understand your microscope to understand what your beam splitter is, what these video adapter tubes are, and what cameras to use. But for most of us, the good news is you don't really have to use medical cameras. We moved from medical cameras, we tried our hands at, these are cinema grade cameras that we are using, significantly 1/3 the price of a medical grade camera, on which feature films are made. So this is by Canon. And eventually I've shifted to pure SLR based recording to the theaters, because simple to understand that the sensors are larger, these full frame SLRs, so the zone of recording is larger and it's crisper. But once you have your setup, doesn't mean you have a good video. Like I said, apart from recording all your videos, you have to pay attention to details, mostly on where you are centered and what is happening. And for that, sometimes it's very difficult, because as a surgeon, you are so involved and so engrossed in the surgery that you tend to drift away. So it's best to zone in or otherwise have a spotter. Like if you see my anesthetist and my technician here, have an eye on a big screen, which is always in the OR, and they tell me very blatantly that you're not centered, despite how bad the surgery is going, or if I'm in a complex maneuver, they've been instructed to tell me to make sure that everything is centered. And I'll just show you a video, and when I talk of centration, this is an old microscope. This is not even one of the latest microscopes. And this is Dr. Vaishali. She's operating a pediatric cataract with an anterior capsular axis, posterior capsular axis, and she's implanting the lens in the bag. What I'm trying to bring out here is it's a toric lens. You want to see how well centered the eye is. You have zones on both the sides. Your area of action, which is the IOL, not the conjunctiva, not the cornea, is well focused. And you take your time to make sure that everything is centered. You use zoom in and zoom out to add cinematic effects every now and then, because when you crop these and show it in these presentations, they will add a lot of aesthetic value. Once you have the videos, like I said before, it's very, in my hand, what works best is to be very myopic in your approach and have that 1 or 2 points that you want to bring across, because you want it to be easily palatable for the audience as well. Like I said, time is limited. So you need to build up a story in that time. You want to start, build up a pace, and then bring it down so that the person and the audience understands. And for that, it's very important to write a script from a narrative point of view and make sure that you time the script. Sometimes points are very difficult to come across, or if they come across, sometimes it's not very lucid. So it's always good to set up some experiments. Now, you don't need to have very fancy labs for this. So I'll just show you. That's my daughter, many, many years ago. Now she's almost 11th, but this was when she was 4. And the iPhone just came up with a high-speed camera. Okay, it's the beauty of using things, like high-speed camera, that these are moments that you can capture. This is the first generation. But then we used this many years ago in ophthalmic surgery. We wanted to see what happened when phaco happens and when these plumes come out. So we bought a camera from Singapore, imported it. That time the iPhones were not there. And the plumes that you see, or the lens milk you see, is ineffective phacoemulsification, causing emulsification, but no aspiration because your ports are blocked. And these plumes are the lens milk that you see. This is just 300 frame rate, as much as what you have in your phone right now. And I paid a huge amount of money for this. But it was thinking out of the box that helped us bring this point across, and we did win an award for this film. Vitrectomy. What we do is a pars plana vitrectomy. And why we do it is to understand that when you drain vitreous back into its natural compartment, you are able to preserve the anatomy and not extend the PCR. As you can see over here, we're doing a vitrectomy, and the vitreous body just prolapses down back into its natural compartment. It's an important concept, but sometimes very difficult to put across. So we decided to do a Miyake apple view. We decided to make our own Miyake apple for this film, and we used an old 1FR microscope, broke it down, put it upside down, hemisectioned an eye, and it's a cadaveric eye. So we are recording from the top, operating from the top, and recording from the bottom. And this is show you, when you do a limbal vitrectomy, your area of approach and your angle of approach is very limited because you're only going through the area of PCR. Only so much you can tackle with a limbal vitrectomy. On the other hand, if you do a pars plana vitrectomy, let me just move ahead, yeah. So if you do a pars plana vitrectomy, not only do you access the area of the PCR, but you can go way beyond it to clear. This is it's a visually striking image of what happens inside the eye, which as eye doctors we don't get to see. We all know what we're doing, but sometimes it's very difficult to see and make out what's happening unless and until you show it from a different perspective. To show the same point, we use a simple experiment, a sheet of plastic and some cotton wool, to show that if you do a limbal vitrectomy, you pull the entire vitreous body up and you enlarge a PCR from a small to this huge big mess. This is typically what happens in a cataract surgery. On the other hand, if you do a pars plana vitrectomy, as you can see over here, you pull it back. And the moment you pull it back, your PCR doesn't enlarge. And this brings the point home. So thinking out of the box sometimes may be very helpful for you to put across that point. Animations play a big role, and this is one of the films where we won the grand prize in the ASCRS. The entire film was based out of puppetery, but I wanted to make animations and we ran out of budget. The one thing that I realized works wonderfully in all our hands is simple PowerPoint. So this is all animations just to show you that as nuclear sclerosis happens, your contrast goes down. And for this, you don't need any high-end setup. You just need a PowerPoint and transitions, and beautifully you can put across loss of contrast and things like that. Sometimes you can make animations, and instead of using animations with the PowerPoint, you can use models like I used clay to show femtodelineation, and how if you remove layer by layer using a femtosecond laser in a posterior polar cataract, the blue being the posterior polar, which is adhered, you can slowly cleave out different areas of the lens by keeping the epinucleus cushion. And when finally the only epinucleus is left, you get gentle wave of fluid can cleave off the posterior polar cataract. Again, simple animation to do or a simple model to make using a simple clay model. Okay, all right. Just move out of this. These are all animations. This is another patient where I wanted to just to go back to this. This patient came to us, was extremely unhappy because he had visual problems. And if you notice, the moment we do a UBM, we realized that somebody had put a multifocal lens, partly in the bag, partly in the sulcus. And the doctor was getting the blame for the multifocality. So we just want to understand the optics. Again, PowerPoint, to show that if you put the eye in perspective and you see one of the major optics in the eye is tilted out of place. And once that happens, you get terrible aberrations, which has nothing to do with the lens, but nothing to do with the quality of the lens, but everything to do with the poorly structured lens. All we did for this patient was push this lens back into its capsular bag and a well-placed IOL, and the patient was comfortable. To finally wind up, I use Adobe Premiere Pro to edit my videos. You can use anything that you want. You really don't have to use complicated things like this. But please give your own voiceover. And for this, I normally rent out radio stations for an hour or two, and I go and give voiceovers, record. This is one of the doctors, Dr. Shail from our institute, giving his voiceover for the film. And now be very wary of copyright, because copyright is a big issue. So please use open source material or make sure that you don't have copyright infringements. And all this over the years has, respect and encouragement from peer has always given us over the years lots of awards. And I thank you for this talk. Thank you.
Thank you very much, Samresh. While Soonpik gets set up, just one quick question. You've given a lot of pointers. Which do you think is the really most challenging part of coming up with a new movie every year?
I think of the many challenging parts, the most challenging part is to come up with the relevant topic.
It's the inspiration, it's the angle, isn't it?
Exactly. And sometimes it's the going back. You don't really have to invent something new, but you have to look at the old thing from a different angle. If you think you know something that has not been brought up, you can bring it up, but you have to be very, very sure of that one or two points.
That's such a good point. My wife is an ophthalmologist as well, and sometimes we look at these movies and she says, "No, that's old, that's new," but you've never presented it. You've never identified that tip or technique as something worth doing, and really that's the essence, isn't it?
Yes.
Focusing in on something and developing it. But thank
Absolutely.
you.
Thank you, sir.
That was great. So our next presentation is by my friend and colleague from Asia, from Singapore, is Professor Chi-Soon-Pek. And there are a few better surgeons than her in doing the complicated lens implants. But I just wanted her to share with you how she developed to be the surgeon she is today, and really for all of us, how to be a better surgeon. Again, something they never teach you in medical school or residency. Soon-Pek.
Yeah. So thank you very much. Many of my colleagues, especially the juniors, say to me, well, I want to be a better surgeon. And I say that to myself as well every day. So how do we get there? So, the residents, they always come to me and say, can I copy your video? I want to learn your surgery. And I tell them, you should watch your own video and critique yourself. You can be your own teacher. So if you look at the video here that my fellow was doing when I was out of the room, well, was the eye centered? Was it in focus? When something happened, I really couldn't see. Sometimes the magnification is so low, I can't tell what's happening. And have you got control of the eye? All right? And what are the events leading up to the complication like you see here? I cannot help her when I cannot see the video. And when she looks at her own video, she'll be astonished how badly centered it was. And second thing is that little things count. And I always tell them 1 + 1 is not 2, it's 3. They add up. All right? So this is the patient's head and face position. If you operate on this patient, you'll find there's difficulty in focusing. You may not find that difficulty when you're young because you've got great accommodation. But as you get older, you'll find things that are not clear at a certain level of focus. So you need to get used to getting the head adjusted so that the face is parallel to the ground and it keeps things always in focus and you don't have to keep adjusting the foot pedal. Now, having the eyelids draped properly is very important, all right? So you can see here draping of the eyelid, and you want to drape the lid margin, not just the eyelid, and you can see how we get this done properly. And then meanwhile, another point here is if you see a sunken eye like this, I always tell my residents, please give a block, even if you don't think you need a block, because that will help you, the oil and the oil from the meibomian glands, that if you do actually drape properly. You can see here, draping done properly, wrapping the drape around the lid margin, right? You don't get oil, all right? If you get oil, it's not because the patient's lid is just oily, but because you're not draped it properly, and you don't get welling, all right? So you can see more clearly. So how about the choice of speculum? To me, it's very important, especially amongst our Chinese population. We have very, very small palpable apertures. So it's important also because these two different types of retractors actually do different things to the eye. So something like a Jeffy lid speculum or rubber bands actually lifts the lid margin off, so there's no pressure on the eye, and the width of the speculum also counts. So the narrower the blade, actually, you can actually retract more widely. So this is important when you deal with small palpable apertures. It makes your life easier. How about the ergonomics? I always tell my students, you should look at me when I operate or a colleague when you operate, not just focus down the scope. Your sitting posture, you can see my two residents, one has an upright posture, the other is really bent forward. Can you improve on this? Because when you get older, you have severe back pain and you cannot do many cases. You get tired. So you want to always adjust the scope so that you can keep your back upright and the eyepiece should be level. And perhaps if you're not that tall, tilting the scope towards you may actually help to save your neck. And also, it's important to keep the eye in the center, and my residents never understand why they end up always pushing the eye nasally. And the reason really is that your eyepiece is too high. You're sitting at too high a position, and that's why you push the eye nasally. All right, so you need to adjust the eyepiece and your seat level to appropriate position so that the eye actually is looking straight up at the scope with your arms relaxed. All right, so you can see, for example, this is my resident. He's looking uncomfortable, and you look at his hand position. He's trying to control the eye position and it's going nasally. All right, so I told him, let me have adjustment for your scope, and let's see how we can do this. So I just got him just a little down, the eyepiece a little lower, so you can see now he's looking straight on. He lowered his seat as well, and now he can drop his hand position. And when he did that, it really helped him to control the eye position better because his instrument's going in at a more temporal position, all right, and he could actually control his eye better without pushing it nasally. So it's important to look at the external view. Sometimes when I'm operating, they're just looking down the scope rather than at the hand. So I look at my students' hands, so you can see how the student is holding his instruments, at what angle, the position, whereas surgeon 2 is putting it more flat, and this is how I hold my instrument. For example, look at the probe. I'm not gripping it, I'm just supporting it, all right? So it can manipulate the phaco handpiece very easily, all right? Where do you rest your instrument so that you're steady? So these are all things that you want to pay attention to. So you can see here from a side view, okay, so this was taken by my AV cameraman, and I was interested, you know, because I never knew this was what it looked like, you see. So there is really no pressure. You want to have everything actually supported. You look at the lid retractors, they're not pressing on the globe, especially when you're doing a lens with loose zonules. You don't want to be pressing on anything. There's no pressure on the globe to push vitreous forward. So it's very useful to actually be able to get a colleague to even videotape you when you're doing surgery to see exactly what you're doing. All right, so this is very helpful for me to know. So think about your incisions. Incisions are very key because it is testimony to your surgery for the patient's life. All right, it's important to look at wound construction, the position, the incision size, the shape. So you want to plan the number of incisions, planes, and I generally prefer a single plane incision, and it should go upwards to the appropriate length. So what is the good appropriate length? It should be about 2/3 to 4/5 of the width so that you do not get all locked. And I like to widen my incision internally so that you have a ability to yaw your instruments without getting all locked and stripping Descemet's detachment. So even if you have a very, very high myope, you don't stretch the incision. And this is how I do a self-sealing incision. I use the infusate from the infusion to actually just hydrate the incisions, and you just press it shut, and I never hydrate my incisions if I don't have to. Okay, so these are important because you have a nice incision with that, and you see the way I lift up my incision to get in, and then once I'm ready, then I turn on my infusion. I can see exactly what I'm doing, and I do not detach Descemet's membrane when I do that. I'm very careful, right? So always respect ocular tissues. Do not just shove in your instruments. So very often my surgeons forget that viscoelastic is invisible and they don't see it and they run into trouble for this reason. In fact, I recently had one of the drug reps come to tell me, oh, someone had a wound burn because they did not aspirate the viscoelastic when they entered and they just started doing troughing. Okay, viscoelastic is invisible. Always remember it's there, it's doing its job, but when you enter the eye, if you have the eye filled with viscoelastic and you have a high myope, you will have lens iris diaphragm retroprojection syndrome, which you need to release like what you saw here, all right? And if you're phacoing in dispersive viscoelastic, you will get a burn at the incision because there is no flow, all right? Because the viscoelasticity is higher than BSS. Now, it's very important to understand phaco-dynamics. It is the key to controlled surgery. So if you do not know how to do this, when you start, it's okay. Your mentor can help you. But as you go along, you need to know how to adjust your parameters so that you can control your surgery even when you have a complicated case. And I think it's always very useful to do bimanual surgery. So you can see here, doing bimanually, I like to hold the eye in position so that it can help me to adjust what I need to do. All right? If you're using two hands to hold instrument, like many of my junior surgeons, for example, doing a coaxial aspiration of cortex, it's very difficult if I say to you, all right, now you rotate the eye temporally, the pupil is coming down. How do you get the cortex subincisionally? You are unable to control the eye position because you are using two hands to hold your instrument. But if you had one on the side port, it is not a problem getting subincisional cortex. Okay, you will never catch the posterior capsule, and you can see better when you tilt the eye. So when things have gone wrong, review your video and identify the problem. Remember that small things don't add up, but they multiply. You need to deal with them when they are small. Analyze difficulties, think out the box for simple solutions. Challenging cases are made simple by logically dealing with each issue meticulously. Thank you very much.
Thanks, Soon Pek. Are there any questions to Professor Chi while she's here? We have a minute or two. Otherwise, I will say that I learned two very useful tips just from that, and I've heard this talk before, and one was the incision, where she lifts it up and doesn't get Decimase membrane detachments. I think we all get a number of them if we don't do that, and I certainly just shove my phaco tip in usually, so I'm going to try that. And the second thing is, I'm one of these people who uses one hand for IA and don't have anything in the side port, but it makes total sense because if you're, in most cases, you can actually get the subincisional cortex out without having the left hand tilt the eye. But if you're in difficulty, I think absolutely that having that tip alone is going to save you from one or two ruptured capsules, I'm sure, to have the side port help you, move the eye up, isn't it? Samresh, yes? Oh, sorry, lady at the back first. Yep, give me a...
when you enter without irrigation, then sometimes you get an air bubble.
But what I do is I enter halfway with my infusion pots, just half in, half out. I step on the pedal, and then I push it in.
So she does step on just before the final entry.
Yes.
Okay.
So I release the air bubble first.
Yeah, if you enter without irrigation on, then you end up getting an air
Yeah, but I just put it half in, half out, step on the pedal, and then when the eye is firm, then I enter in.
Samresh.
Just wanted to know the ergonomics was amazing, but do you rest your elbows on an elbow rest or you don't have any? Okay.
No, I rest it on the patient's cheek and forehead.
Yeah. All right.
Thank you.
Thank you very much, Soon Pek. So our next topic is how to innovate. And originally, Dr. Sri Ganesh gave this talk for me in Singapore because his center is one of the most innovative. He unfortunately has had some surgery recently, so he's unable to become. But his able deputy, Shital Bra, is here to deliver the talk on how to innovate. And Shital herself, in her own right, is an extremely innovative surgeon, as you all know. Shital, welcome. Thank you.
Thanks, Ron, for the kind words, and good morning, friends. I'm stepping in for Dr. Sri Ganesh for this talk. He is one of the truly most amazing, innovative surgeons I have ever seen in his life, and I had the privilege to be trained by him. And I was with him in my fellowship for 2 years, and then I worked as a consultant with him for the next 8 years. So 10 years being with an innovator, also makes you think in that way. So I'm going to discuss some of the innovations that he made, and I was also part of these innovations. So innovation does not happen overnight. It is a series of events and process that start from identification of the problem, framing a research question, then you have an idea. So you have to have an idea, and then you define the need and understanding of the opportunity. So you need to innovate. Basically, there has to be something that propels you to think in that direction. Is there a need for that? So you have to identify the need first, and then come up with an idea, and then you go on to innovate. So you create a design, you develop a test, and then you implement it in wet labs or otherwise, and then you basically test the proof of concept and risk analysis, and then you get onto the stage of testing the prototypes and clinical trials and filing of the patents, fundings, etc., before it eventually gets commercialized. So it's a long process, and this is unfortunately something we are not able to learn in our post-graduation. So we all know that necessity is the mother of invention, and this is what basically makes the foundation of any innovation that we do. So Dr. Ganesh in 2016, he innovated the capsular fixation IOL, and this idea he got basically when he was swiveling the stand of his bike. So he got this idea when he was basically pivoting it, and then he thought that why not create a lens that has two swivels that can pivot, and this is how he came up with this idea. And this was essentially made to basically tackle the problem of effective lens position. So we all know that in the bag lenses, eventually over time, their effective lens position changes, and also in the case of toric lenses, the lenses can rotate. So this lens basically has two extra haptics, and these haptics can be rotated or pivoted onto the capsular axis, and that fixes the lens, or you can say it locks the lens to the capsulotomy. And you can see in this particular case of toric IOL, the lens position is very well stable, and there is no rotation, and the lens is in its intended position. So this was one of his innovation, and this is another innovation wherein he basically wanted to tackle the problem of toric IOL rotation in small pupils. Now we all know that this is an issue when we implant a toric lens in small pupils. At the end of the surgery, we need to use a second instrument to check the positioning of the lens, and this increases release of the pigments, can lead to post-op IOP, a lot of manipulation, IOP spikes, etc. So basically he was thinking what can be done for this problem, and then he kind of came up with this idea when he was exercising in his gym, and when he kept the barbell on the foam seat, and then we lifted the barbell and he saw that there was a mark. It left an indentation mark, and that's from where he got this idea of making a cystitome marker, a toric IOL marker. So in this marker, there are two windows. This is an animation. This is a real case. You can see there are two windows through which you can see the marks of the toric IOL. And in the center, there is a linear projection. You can stain it also, or without staining also. You just you press it on the IOL, and it just leaves an indentation mark. And then you load the lens and implant the lens in the capsular bag. And you don't have to worry about the pupillary constriction, because you will always be able to see the mark in the center, and hence you can achieve proper positioning of the lens without worrying about the pupil size coming down. This is another innovation, basically Ganesh and Grewal cystitome maker, which was done to tackle the problem of manual cystitomes. So when we make manual cystitomes, sometimes the bend is not accurate, the angle is not accurate. So, CCC is one of the most important steps in cataract surgery. So this is essentially a pair of locking pliers in which you place the 26 gauge needle, keeping the bevel up, and then you lock the pliers and bend the needle, and you exactly get the desired amount of the angle and the projection. So basically this is based on the standard 26-25 gauge irrigating cystotome, which is available with Alcon. So when you use this, we did a study basically to see how reproducible it was, and we found that it did help us in creating very reproducible capsulotomies without any complications during the surgery. There were no problems with initiation of the capsulorhexis or extension of the CCC, and it was also very convenient to use. This is another innovation, PCR safety net, wherein I had the idea of making a safety device to prevent PCR, to prevent nucleus drop in PCRs, and I discussed with Dr. Ganesh. So we designed this PCR safety net, which is a temporary rescue device which you can use in the face of PCR with fragments in phaco during the phaco stage. So of course you can't use it when the PCs have already descended. So just, it's a foldable hydrophilic device. It has small circles in the center and 4 large circles of 1 millimeter in the periphery. So you fix the device first by making 4 ports and using iris hooks. You really don't need to use 4 iris hooks, you can just use 3, and you can emulsify the fragment, and in the end you can remove the device by simply pulling it out. So the advantage of this innovation is that you can do a proper cortical and vitreous cleanup. You know how much support you have before deciding about your choice of intraocular lens, and you can manage the PCR without extending the wound. So normally we would sometimes extend the wound, the corneal wound, and then remove the piece, so it doesn't induce that much corneal astigmatism. So some of his other innovations were lenticuloschisis, the no dissection technique, Philly, which is another technique wherein you use smile lenticules for correction of hyperopia as well as keratoconus, manual compensation of cyclotorsion in smile, and visco chop technique for soft cataracts in femtolaser assisted cataract surgery. And he has also designed some instruments for smile procedure. So friends, research is not just a frame of mind, it is a process, and anyone can innovate if they have an idea and also the right approach to innovate. Thank you so much.
Thank you very much. Shita, just one quick comment. So I like the toric marking thing,
Yes,
because we get quite a lot of small pupils. How long does that indent last for? Do you have to rush and get it aligned?
Yeah.
And is it available yet commercially?
Yeah. So the mark lasts easily up to 2 to 3 minutes.
So enough time to,
You have
to
enough
get
time.
OVD out?
Yeah,
and
yeah,
align
yeah.
it.
In fact, in some cases, it lasts for even longer, because we have seen immediate post-op also. Patient after 10 or 15 minutes after the surgery, you can still see the faint impression.
Right. And is it available yet?
It is, yes, it is available with Epsilon.
Epsilon.
Epsilon Surgicals. Yes.
Okay, thank you very much. Sunpek, any comments?
I think I really admire Sri Ganesh for his great innovations. And I think sometimes, we have an idea, but we don't know how to develop it further.
Correct.
And getting the right industry partner to work with, sometimes, I think in India it's much easier. You have many people who will come forward and help you with an idea. But for us in Singapore, to reach out to someone may not be so easy. So I think Sri has really done wonderful work, and really he's to be congratulated. Thank you very much.
Thank you. I'll definitely convey to him.
Yeah.
Thank you so much.
Thank you, Shital.
So I think our next speaker needs no introduction. He's Dr. Ronald Yeo, who is the past president of APACRS and the chair of scientific program, and today, you know, he's going to talk to us on how to deliver a memorable lecture. I think he's given many such lectures, and even though they may not have been always a named lecture, it's always memorable. So Ron, please.
Thank you, Soon Pek. You know, I deliver many lectures over the course of a year, and I hate to waste 10 minutes of your time. If you think about it, it's 10 minutes of your life that you're sitting in here. So I think the worst crime in our life is to deliver a terrible lecture. So, you know, I don't claim to be a fantastic speaker, but I can tell you I've heard some terrible, terrible lectures in my lifetime. And I'm sure some of you have too. One comes to mind. Many years ago, I invited a speaker to come, and she started off by saying, I don't really know much about this topic. I mean, you know, that's not going to inspire confidence, is it? I mean, you don't really start a lecture off that way. Some lecturers are very rambling. They go all over the place without focusing. Some people have terrible PowerPoint slides, which are, you know, poorly designed. And what's worse than a complicated slide is reading off a complicated slide, right? I think you all have gone to school. You don't need me to read the slide out for you that's up on the screen, right? So that's something that's not a great thing. Now, some people speak in this inaudible monotone throughout their 10-minute lecture. And if you don't fall asleep, I would fall asleep as a speaker. So you've got to have some enthusiasm and belief in the topic that you're speaking. And quite commonly, and I would say this, in India, sometimes the lecturers go on a bit too long over time, you know, but this meeting has been good. Everyone's been on time. It's been fantastic. But perhaps the most common crime, I would say, is that you have a lack of a focused message or a take-home point. Remember, the PowerPoint presentation is just a guide for what you're going to speak. It's not to be read out. And in many cases, the simpler your PowerPoint slide, the better, and less is indeed more. So what makes for a decent lecture, okay? Well, first of all, your topic's got to be reasonably interesting. You obviously need a bit of expertise in the subject. Now, it's got to be consistent with the theme of the symposium. You know, every meeting has a theme, every session has a theme. You've got to keep with it. Now, of course, if you have new data and research, that's absolutely important, but you don't always have to have it. But as I've said before, a clear message and conclusion is critical. That's not enough. You might have all these points, but your lecture might still not be memorable. So what makes a decent lecture memorable? So number one, you need to have some in-depth background knowledge of your topic, know your subject, but just as importantly, know your audience. I can see out here we've got a mix of ages. We've got some very senior people, some middle grade people, and some junior people. And sometimes it's hard to tailor a talk when you've got a very diverse audience. But you also need to know the market or the environment that you're speaking in. Now, something that's not appreciated sometimes is you've got to know the other topics in a session so that you can put your talk in context. Perhaps not so much in this session, but in, say, an IOL session or a refractive symposium. You need to know what the other talks are so that you can kind of slant your talk and complement the session better. Planning your lecture is absolutely important. What's your message? Tell the story that you're going to tell in the allotted time. It's a bit like making the movie that Samresh was saying. You need to tell that story. It's always useful to add a little anecdote. And of course, powerful PowerPoint design is very important. And what you need to do is collect useful images and videos over your career and archive and file them away so that you can pull them out to really improve the quality of your lecture. Now, here's something that's very basic and very silly, you might think. So tell the audience what you're going to tell them. Like I told you at the beginning, I'm going to talk to you about how to deliver a memorable lecture. At the beginning and in the middle, I'm still telling you. And at the end, I'm going to tell you, I told you how to give a memorable lecture. So there's no mistake. You know, audience sometimes are a bit, you know, not too bright and they kind of lose your train of thought. So you got to do that. Inject a bit of a humor. Use memorable moments. So this is a picture I took some 20 years ago in Borneo. And I've used this slide in several lectures of mine over the years, and you can caption this. We should run a caption contest for this. So one of the captions I use is, this is how I do a toric IOL alignment. Or a real doctor doesn't need a slit lamp, right? So these things lighten and really brighten up your talk. You need to communicate with your audience and develop a relationship and engage with them. So in other words, you speak with them, not necessarily to them. And I learned quite a useful tip. You know, when you're talking to an audience, say, full of people, you want to address the person who's sitting in the last row there. Because if he's listening to me and can hear me, everyone else in front of him is also listening to you. Avoid speaking to avoid, in other words, aimlessly, and that's why I don't like virtual talks. When I give a Zoom lecture, I have no idea whether you're listening to me or you're picking your nose. You know, who knows? So relate content to real situations. Like I dropped a nucleus yesterday because I didn't listen to Professor Chi. You know, you can relate to that. That is real life. These events happen. So speak loudly and confidently as far as you can. Now, we can't all be blessed with a great, loud voice, but think about it. If you've got a very soft, weedy voice, it's even more important that you develop great lecture technique. Now, you need to develop this nebulous thing called podium presence. I mean, what is podium presence? Podium presence is when somebody stands at the podium, you stop whatever you're doing, and you're going to listen to him. Now, of course, politicians are the ones who really have podium presence. Lee Kuan Yew, our former Prime Minister, JFK, Churchill, Martin Luther King, and I'm sure many Indian politicians. But in ophthalmology, my previous boss, Arthur Lim, Amar Agarwal, when Amar speaks, you dare not look away, right? You listen. John Marshall, Brian Little, Bobby Osher, Donald Tan, Mohan Rajan speaks so loudly, again, you can't stop but listen to him. David Chang, Eric Donenfeld, they're all very good. Were they born orators? No, they all over the years developed their speaking technique to what they are today, such that everyone listens to them. It also helps, of course, if you have a fairly thick skin and really an overabundance of confidence. It's really helpful. Practice makes perfect. The more you do it, the easier it comes. Of course, the day you become a resident and the day you graduate from residency, you're expected to stand up here and speak among all the luminaries. It's a bit daunting, but the more you do it, the easier it becomes. Now, it also looks good if you are famous and good looking. So like my sister, Michelle, who won an Academy Award in Hollywood last year. So, sorry, you can't hear that. But when Michelle speaks, people listen. But you and I are not as famous as she is, so we need good speaking technique, don't we? So you also need to pay extra attention to the start and the end of your lecture. And the start doesn't mean just saying a good morning to everyone. You know, look at the people, address them, relate to them, engage the audience, and you need a powerful summary and conclusion at the end instead of just letting it peter out into nothing. So, just to end with, so when does your decent lecture become memorable? Okay? It becomes memorable when a few handphones, I see one or two handphones recording and taking photos of my slides and my talk. You know, people are listening. When I can see that people are paying attention and not chit-chatting to each other, when there's some questions and discussion at the end, when delegates change their practice because of your lecture. Now think about it. I mean, if I've given a lecture to you and you go home and just do things exactly the same way without adopting the technique or modifying your practice, I've wasted your life, I've wasted 10 minutes of my life. So that hasn't worked. But perhaps, you know, one memorable incident comes to mind when someone tells you later that they remembered a certain lecture you gave and thanks you for making a difference to them and their patients. And this happened to me a few years ago. I was swimming in a swimming pool in Thailand, and somebody swims up to my son and me. My son was 15 at that time, and says, "Dr. Yeo, thank you for teaching me to phaco. I still have your notes from 20, 30 years ago. Thank you." And he swims away. Then my son, and you know 15-year-old teenagers are impossible to impress, right? He said, that was pretty cool. So that, you know, brings home the privilege that we have as teachers and the duty we have to our audience to really deliver decent, if not memorable, lectures. Thank you very much for listening to me, and I hope you all give many more memorable lectures. Happy to take any questions or comments, Soon Pei.
Yeah, thanks, Ron. That was a great lecture. I think what I have always learned from you is less is more. Okay, I think we often cram too much information, and if you're just listening to the speaker for the first time on this topic, you can't absorb everything. So I think less is more, then the message becomes crystal clear.
I'm glad that you changed your practice because of me. You should have seen her slides from 20 years ago. There was no background, it was all text. Right? Do you remember some of your slides with drawings and arrows?
Yeah, so fewer words is better. Yeah. Definitely.
Great.
Any other comments?
Otherwise, Namrata.
Okay.
I'd like to thank Namrata Sharma for inviting the APACRS to present this masterclass here in Kolkata. And it gives me great pleasure to ask her to talk to us on how to do memorable or meaningful research. Namrata, thank you.
So it's a daunting task to follow you first of all, and then to follow your memorable lecture, and then to see, you know, what mistakes I've already done. I was just thinking. Anyway, that was really very good, Ron, and thank you so much, APCRS, for joining hands with the AIOS for this session. I know you both have traveled only for that. Thanks a ton, really. Thank you. So I am going to be talking to you about how to do research and publish in ophthalmology. Publishing and research is, of course, my first passion right from my postgraduate days. And the reasons for research could be any. It could be if you want to ask a question, if you want a diagnosis, or if you know how to, what is the treatment of that particular thing. But I think more importantly, when you're beginning your career, you don't actually start thinking that. So your goals are different. You either want to foster a future mentorship with a notable researcher, or you want to strengthen your curriculum vitae application for vocational subspecialty training or to get a job. So I think those are the two things which motivate you right in the beginning. The bright side is that it is intellectually rewarding, it is emotionally satisfying, and it provides direct and indirect benefits to patients and society. The flip side is that you need to find a mentor, you need to find support for funding, and you need to reinvent yourself. So how to commence a research? It is always best first to get mentors and collaborators. You may be involved in a running project, or you may just write a case report or a rare presentation or a new intervention or a new therapy. Finding a research topic is important. You should confirm the suitability of the topic, develop a hypothesis, plan study design, calculate sample size, and then execute the research. Now, once your research has been executed, it could be anything. You could begin to write with letter to editor or just case report. Then you graduate to doing retrospective clinical studies, questionnaire studies, finally prospective studies, and then maybe randomized controlled studies. It is important to know what is the gap in the knowledge, because no point doing something or trying to do something which people have already done and published on. Like Samaresh said, you have to find a new thing, a new indication, a new complication, a new way of doing things. Of course, if your research requires help of a statistician, you should always take that, especially for the power and the design of the study, because otherwise it will never get published. And very importantly, you have to take ethics committee or IRB approval for that. It is important to identify the main concept, to see the measurable indicators for each concept, to rewrite the preliminary research question in really operational form. And I think something that I did not pay attention to, and that when you are junior you don't pay attention to, is that you have to present. Before you publish, it is important to present in meetings. You know, there are meetings where everything will get accepted because they want you to be there, but there are meetings which will have limited acceptance. So you have to know that before you actually publish in the, present in the meetings. It could be in the form of posters, papers, instruction courses, or videos. And more importantly, you have to be a part of a group, because you cannot go everywhere. So even if one of you goes and presents it, you are represented. At least your name is there in the group. So this is what I have, about 600 plus publications. And it has been an uphill task in various journals. First, we used to start with a journal which which had a impact factor which was less, and then gradually you go on to graduate to a journal which has a greater impact factor. So this is some of the examples from my own journey. So when phaco came into being, it was a new thing. Capsular staining came into being, it was a new thing. So whatever we did, even if it was a case report or a different technique, or there were ways of doing nucleotomies, etc., everything we published. You can see all of them are from 2002 to 2008. So important thing is that you have to be so restless that whatever new thing you do, you should be able to document it, and it doesn't take too much time writing it down actually. Likewise, when refractive surgery came, so we had a LASIK machine. So again, if you see the order, it is from 2007 somewhere to 2010, and we acquired the LASIK machine in 2000. We started publishing a little late, but then everything that happened with it, we published it. Now this is what I want to highlight is a power of an idea. The trypan blue staining of anterior capsule was published by Jared Mallis in JCRS, as a letter to editor. So it is important, if you have something in mind, run and publish it, because if you don't do it, others do it, then you're going to feel bad about it, because you've been doing it for so many days. The only thing is you've not penned it down. The SLET technique by Dr. Sangwan was again a BMG case report. Tuna packet injury as a mechanism of ocular injury, which got published in Lancet, it's a small paragraph there in Lancet. But then, if you've reported it first, it will always be cited by other authors. Something that you do very normally, sometimes you think that it's so normal to do it. Like in India, we don't have good quality donor tissue, so it's so normal that from one tissue we try to treat 2 or 3 patients. So, but when we realized in 2011 that it's not published, but I'm sure our Indian cornea specialists have been doing it for years together, because that has been a problem. So as soon as you realize that it's not done and you do it, like for instance this paper where we used 1 cornea for 3 recipients, anterior posterior keratoplasty as well as for stem cell transplantation, it got published in 1 shot, because nothing like that was there and it hardly required any revisions. Sometimes the journal helps you. For instance, this case, we had a case report, we sent it as a case report, and they said, why don't you do a review article, because we are running short of reviews. So, it became bigger than case reports. So sometimes the journal, people who, review really help you to do it. Now you have to be vigilant, like I said. There was this movie on double bubble DALC, which won awards throughout the year, but we didn't publish it. And when we sent it for publication, it got rejected, and 2 months later, it got published. So we were not fast enough. We sat on the laurels of our surgical video, which had won awards, but we did not write it down. So I think it is very important to do that. Then there are certain things which, as you go, for instance, you would say, for instance, if in cases of ocular SJS, we were seeing that there were a lot of corneal ulcers. We just wanted to study the microbial flora, so that got published. And as you keep publishing, you become a part of collaboration. For instance, SLET we were doing, and so when there was a multicentric review article and studies, they would make you a part of it. Then, like I said, whenever there are new devices, and I'm sure Ron is going to agree with me, intraop OCT, so as soon as intraop OCT we acquired, whatever we could see with intraoperative OCT was, like magic, and so we published it in all possible forms, whether it was case series or case reports. Likewise, for femtosecond cataract laser, as soon as we acquired it, we tried to publish it. Now, all things may not be researched. Like I said earlier, this was moxiflox versus combination therapy in non-perforated bacterial corneal ulcers. We thought that in all textbooks it was written that combination therapy is good, and we realized that there was no RCT for this. So we quickly ran and did the RCT and got published in ophthalmology. Likewise for Gatiflox also. Now sometimes, there's another group which is doing a similar study like this one. Arvind was already doing, Arvind Eye Hospital was doing a similar study on fungal keratitis. So we changed the way we are going to do our study. No point repeating, what they are already doing, because you would come out with the same results. So you have to be quick to know what others are also doing. And on the clinical trial website, these trials which are being done are already there. So when you plan your trial, you be vigilant to see, what you're going to do. Now this was accidental acute chemical injury into a ditch. 31 people fell where there was sodium hydroxide. So we didn't do anything except that we documented it. And this was a very unique cohort. Where in the world would you get 31 people who fell down into a ditch with sodium hydroxide and are being followed for 2 to 3 years? So all this paper needed was documentation, and it got published in American Journal of Ophthalmology. So like I said, always publish after you present. So you go to AAO, publish in ophthalmology. You go to ASCRS, publish in JCRS. And this was our plight that I was talking about. Won awards but could not publish it. Finally found a journal which was, not that significant, with not that high factor, but only to boost our ego that, it has got published. Finally, we went and published it there. Now, rejection doesn't mean that it's not, whenever it comes to your, rejection comes to you, it means it's not their priority. If a particular paper is rejected from a particular journal, I don't think you should feel bad about it, but don't keep in your laptop for more than a week. Immediately resend it. Because if it's in your laptop, it's never going to see the light of the day. But if it is on the net, someday it will see the light of the day. Change specific categories, change journals, but don't keep it in the laptop if your paper gets rejected. Change continents. So if your papers got rejected from AJO Archives Cornea, that means you're targeting US. Those are the reviewers. So change your continent. Go to UK. We submit an I, British Journal of Ophthalmology. Reviewers would change. If it gets rejected from there, go to Australia, Clinical and Experimental Ophthalmology. The reviewers would change. And by the time you would have addressed all the others, reviewers' comments also. Continuity in research is very important, I think. For instance, if when you publish in a particular field, then you write review articles, you have patents, and then people invite you to Survey of Ophthalmology or Current Opinions to write review articles on a particular subject. So this is like chemical burns, and then we did randomized control studies. Then we became a part of collaboration of chemical burns and acute Stevens-Johnson syndrome, larger group. So to conclude, I would like to say that all ophthalmologists in the world are intelligent. All of us are thinking alike. You don't have to be smarter than them, but you have to be faster than them in conception of an idea, execution of an idea, and publishing the idea. Thank you very much for your kind attention.
Thank you very much, Namrata. I think that was a wonderful talk, and again, I learned so many things. Amongst them, don't give up the first rejection you get.
Yes.
Samresh is like our movies, right? I mean, I don't know how many rejections or failed to win we got before we won our first award. So don't give up.
Don't give up. So just to give the highest number of rejections that my paper has had is 17, 1-7. So 17 times it can be rejected, but still it got published at the end of the day. So that is what I'm saying. Don't keep it in your laptop. I think that is most important.
Yes, the second
Let
question.
it remain on the cloud.
So I was interested in your comments about case reports.
Yeah.
I mean, it used to be poo-pooed a little bit, right? I mean, the mainstream academics would, look down a little bit on case reports, but I think you've highlighted that it is relevant.
Yeah.
And I think JCRS now has a section just on case reports, if I'm not mistaken. Any comments on, whether, I mean, it's a good place for residents to start, isn't it?
So I think it's good for residents to start. Some of them are important case reports, and some of them, like I said, if they are very meaningful, they will get quoted every time, because that will be the first thing that, that would be reported about it. But for residents, I think they should start with case reports.
So Soon-Pik, I'm going to ask you this because you're on the editorial board of the JCRS. How often do you get a paper submitted that one reviewer says accept and one reviewer says reject? And how do editors resolve that issue?
Yeah, I think it's quite common. And depending on, how high the ranking of that journal is, so I also sit on the AGO for cataract inflammation as well. And if one says yes and one says no, I just reject it.
That's a bit harsh, isn't it?
Yeah, I thought as much.
I look at it, but if it's valid, I would just reject it. Whereas if it is a lower ranking one, like ocular inflammation, immunology, we're a bit more generous. Then we say, oh, maybe we send it out or we take a decision. Yeah, but sometimes, I just rejected a paper outright, just based on the content, and I didn't think it was valid, so I just rejected outright. So sometimes it never reaches the reviewer. And at other times, they send topics which are very difficult because, I can invite 20 reviewers and no one accepts. And then sometimes we have to just reject it because we can't find a reviewer. Yeah, so perhaps, they should send it to a different journal.
Great. So I think we're nearing the end of the session. Are there any last-minute comments or questions to any of the speakers on any of the topics that have been presented? Otherwise, yes, sir. Please come to the microphone.
I would like to ask a question about your surgical techniques. Often I find that with the Alcon blade 2.2, I can construct the wound quite nicely, but with other company blades that I'm using, I don't have that mark. So I'm slightly short in the width, in the length of the tunnel, or it's not proper. So at the end of the surgery, I find often I have to inject air bubble to maintain the conformity of the antechamber. So what is your view on that?
I would suggest you increase your magnification when you create your incision. In fact, I do that as a routine because I want to know, because I create single plane incisions, I want to know when I'm going to enter the eye. So I actually increase my magnification so I can see. If you do it under low mag, you might enter too early, and that's when you need air bubble.
A lot of residents don't appreciate that the moment you enter the anterior chamber is critical. They just go into the cornea and they're not even sure they're in. And once you're in, the other thing I teach my residents is don't dawdle, because once you've got a patent passage, if you dawdle and take your time completing the full width of your incision, you're going to lose your chamber. So recognizing that point of entry is absolutely important, and I think the high magnification certainly helps. Any other comments? Otherwise, thank you all for joining us for this session, and thank you to the AIOS again.
Thank you, Ron.
Thank you.
For making this happen. Thank you.
Oh yes, can we have a photo, please? Speakers, come to the stage.